Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humor and a lot of heart. So pull up a chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins. I am Dr. Rebbecca Hertel. I'm a board-certified osteopathic family medicine physician and a Menopause Society certified practitioner. I have a private telemedicine practice, and I see patients in several different states.
I am Dr. Aoife O'Sullivan, a board-certified family physician and Menopause Society certified practitioner, and I see patients through my telemedicine practice here in Oregon and Washington.
I'm Dr. Hart Kress, a board-certified women's health nurse practitioner and menopause certified practitioner, and I see patients via telemedicine in several states as well.
Welcome back to the Dusty Muffins, where we talk about hormones, sex, science, and stuff women were never properly taught about their own bodies. Before we dive in, we want to give a gentle heads up. Today, we'll be talking about trauma-informed care and human trafficking in a broad and educational way. We're not recounting specific stories, but even discussing these topics can feel heavy for some people. With everything happening in the news lately, including high-profile trafficking cases, we recognize this may land differently right now. Please listen in a way that feels safe for you. It's always okay to step away.
If you've ever felt dismissed, rushed, or braced yourself before a pelvic exam, you're a clinician who wants to do better but isn't sure how. If you've wondered how trauma lives in the body during menopause and beyond, this conversation is for you. So let's get into it.
Today, we're joined by Dr. Heather Quaile, a double board-certified women's and gender health nurse practitioner and advanced forensic nurse specializing in midlife care and female sexual health. She is a Menopause Society certified practitioner, a sex-certified sex counselor, and a sexual assault nurse examiner. She is founder of the Show Center, creator of the Q-Spot clinician education platform, and host of the Just Ask podcast. Dr. Quaile has spent more than 25 years caring for women across the health-illness continuum and is deeply committed to trauma-informed, dignity-centered care. She helped establish Georgia's first human trafficking emergency stabilization center and is actively involved in legislative advocacy on issues impacting sexual health, trafficking survivors, and advanced nursing practice. She's a fellow of ISWISH, AAMP, and MPWA, serves on multiple national advisory boards, and continues to educate clinicians around the world. And somehow, she also manages 3 sons, 3 rescue schnauzers, and a husband of 29 years. Heather, we are so honored to have you here.
Friends, I love being here.
Yay!
Hey, thank you for having me.
I know. I knew
love
about,
that.
I know your credentials, but oh my goodness, Heather.
I know. I love it.
She's a little bit of an overachiever.
Just a little, maybe a little type A.
Well,
You guys wouldn't know that though, right?
Not at
Smidge.
all. That's okay.
All the worlds. We need type A's, type B's.
We
Oh
do.
my gosh. Yeah. Yeah. Absolutely.
well,
We're all a smidge type A too.
I'm an AB.
I'm a more A. Sometimes my brain wants to be B, and then my A likes to argue with the B.
Yeah, I think you and I are very similar in a lot of ways, Rebecca. I'm like,
Yeah.
both really, really type A. And forgive me because they're blowing in the backyard of my yard. I'm like, go figure.
That's all right. I really can't hear much of that at all.
Okay, good.
So
Well, it means you have nice weather because we're all dealing with snow on the East
No,
Coast.
it's cold.
it's so cold. It's mean.
Well, hopefully, it's almost March, so hopefully we can have some thoughts coming soon.
Yeah,
Yeah.
absolutely.
All right, Miss Heather. So let's kick this off. So, many women in menopause have a trauma history, and we hear it when we do our intakes, whether it's assault, birth trauma, medical trauma, coercive relationships. How do you see that showing up in symptoms, or how does it show up in the exam room for many clinicians?
So obviously we're all menopause providers, and people who are listening to this know a lot of the symptoms. It'll be that sleep disruption, the anxiety, the panic, the hot flashes, and a lot of those vasomotor symptoms. But one of the things that I really want to spend some time talking to you about is really kind of understanding the nuances of when it's trauma. And this is kind of more than just those vasomotor symptoms. So these are the type of people that you'll often see that maybe like over apologize, or they're people pleasing, or they're minimizing, like, oh, I'm so sorry to bother you with this, or I'm fine, it's not that bad. These are words that are coming out of the patient's mouth. They have a really difficult time being able to like consent or choose, like their body tenses, and you can just kind of see it in their eye contact with you and in their tone. They sometimes will disassociate, like they get this flat affect, they might stare away, or they may check out. They also are usually very control freak type people. They want every detail. They want to sit near a door. They might startle with a noise. And then oftentimes there's a body mismatch with their body language. So they may be smiling while they're describing pain, or they're laughing when they're talking about distress. They definitely present a little bit differently when there's a trauma history that's there.
And so when you have a patient like that, how do you approach something, say, like a pelvic exam?
Yep, absolutely. So when I know there's a trauma history, oftentimes I start it even with my intake questionnaires. So the first thing I will have on my intake questionnaires is I ask them all the sexual health questions, like, is there pain with sex? What does sex look like for you? What do you want? Do you orgasm? And then we kind of dive into the next intake questions of, is there a history of trauma? Sometimes I'll have patients that I'll answer that right off the bat. And so I know before that actual first time I ever meet them, that I'm walking into something like that. But oftentimes they don't. And they want to kind of test the waters out first with you. So oftentimes when I'm doing a pelvic exam for patients, I usually never have a pelvic exam if I can avoid it in the first experience with me. I usually want them to come in. I want them to have a place where they can talk to me, tell me their stories. And then if they feel like they want to do the pelvic exam, then we schedule enough time usually, and that's the beauty of not having to be in an insurance model, is we schedule the time to do that. Or when I talk to them on the phone before I schedule their visits now, I often will say, you're coming in for a sexual medicine visit. This actually includes a physical exam. Would you rather break this up into two components? Because I think we have to just be really, really careful about doing that type of exam before a patient really kind of gets to know you and develops that kind of trusting relationship. And then I think it comes down to really giving them control in that relationship. I try to come to every single experience thinking that someone has a history of trauma. And that's kind of what guides my North Star for me. Because if I come with that in the back of my head, that any of us sitting here in this podcast has a history of trauma, and it may look different for everybody. It may not be a sexual assault. It may be a type of trauma just from words that were said, emotional trauma, work trauma, war trauma. I think sometimes we look at trauma as this big T word, and really it is more of, there's little t trauma and big T trauma. But to kind of answer that question in a whole roundabout way, I really come to pelvic exams giving people a lot of choice, explaining exactly what I'm going to do. I give them mirrors in my exam room so that they can watch the whole thing. And I'll also even allow them to put their hands over mine or to guide them so that they can even self-insert speculums if that's their preference.
I remember my first pap smear, and the doctor said, okay, are you ready for your pap smear? She had just walked in the door, and I said, okay. And she's like, okay, get undressed. And she just sat there in her chair watching me while I got undressed, and I had to sit up on the table, like, just so bizarre. But I feel like even, sometimes we have so little time in clinic now. There are even places where, you haven't been before, you haven't met the doctor, and they will get you into a gown, for that first visit. And so you're meeting that doctor for the first time already with this power differential. You're sitting there naked under a gown, and you're meeting this person for the first time and about to have that examination. And it really does put you on the back foot, doesn't it? Like you don't feel like yourself at all.
Exactly. And it makes it tough too, because usually in an insurance model, it's harder. You're in a paper gown and you're sweating half to death as a
Yeah.
female all over the place because you're nervous. You've never met them before. I never will see a patient unclothed ever in a first encounter. If they're new to my practice, and that's kind of why I stepped away from traditional medicine, is to really take that trauma informed lens, because I feel like we miss it so much in the female space. Not everyone gets this option, and I fully understand that, and not everyone can afford that. But at least if someone can take 5 or 10 minutes with the patient before they're undressed, you've got to be on that same playing field with the patient, because it creates a very different hierarchy structure and dynamic. And oftentimes that's, I think, why women get so dismissed and they're not heard, is because they will come in and just have 2 seconds and you're already naked before you go in there.
And, I always, when I was doing pap smears, I used to make sure the medical assistant helping me was to the side of the bed where I go to have mine done. The medical assistant stands at the end beside the doctor doing it. And she's like literally looking up, looking at my genitals, looking at what's going on. And I'm like, why is that necessary? There's no reason for a medical assistant to see any of that. They should be beside the bed, So it's all these little things that really add up. And women don't want to go back then for another exam after that.
Exactly. And I think one of the things I kind of want, you just touted another thing that we don't talk about. I think we need to get away from our wording. I think that we forget sometimes that words that we use very commonly to describe the female exam, it's like, we need to stop using the word stirrups. It's triggering. Something like a footrest, a leg support, a foot holder. Getting away from the word bed, because if someone was sexually assaulted and it happened in the bed, that is very much a time where they disassociate or they get those trigger words. So maybe calling it an exam surface, a table, and never tell a woman to relax. I mean, that exam is not relaxing at all. So oftentimes I'll even say, okay, we're going to come down to the bottom of the table. I know it's going to feel like you're falling off that edge. Promise won't let you fall. And then I usually will guide them like, here's my hands out here. I just want you, when you are ready, to take your knees and touch my hands. And then I hand them a mirror and I show them how to use the mirror and what we're going to do. And instead of saying like, open your legs, spread your legs, it's like, just part things. Let me gently touch the tissues. Let me touch the outside of your thigh first. Is it okay for me to touch you? Is it okay for me to proceed with this exam? Don't tell them it's going to be a little pinch or you're going to feel pain. Like, having all of these words and these conversations is so important before starting the exam, so that you're not trying to do it in the middle of the exam, and then really utilizing proper terminology that is very like gender neutral, not triggering, and things of that nature, I think are really important.
I think one of the things that I notice is that, and I think it's important for clinicians, like when you're in that insurance based model, or when I was myself in that insurance based model, I was thinking about the questionnaires, and the questionnaires did not specifically ask if they had any trauma, whether it's emotional, sexual, or physical trauma. And, and then of course, time restraints. I mean, I will admit, I never saw a patient for an annual until they were already undressed, because I had, 12 minutes to get it done. So, inevitably, a few times, but for the most part, not, because otherwise, after you're done talking to the patient, then they have to go to the bathroom. And then next thing you know, you're into two patients, and so it's not a great place. But, I noticed that in telemedicine practice that my patients, I've been really surprised at how much more they are willing to share that information in a first visit. And I'm thinking back to some practices where we probably didn't have it in our intake form. So I wouldn't have known that that exam maybe needed to be a little bit different on the onset of, this is a patient who would benefit from not being undressed. And maybe we didn't do their annual this visit. Maybe it was just a talking and then come back and we'll do the annual at the next visit. And so I think it, probably in the telemedicine space, when there is this distance, it's a little bit easier for patients to share those, because there isn't going to be a touching piece of that exam. And then I think the other thing I wanted to ask about how trauma presents. Do you find that it also presents in patients who perhaps don't have tolerance for some of the hormone therapy. Like I've got some patients that, if it doesn't matter what we do, they can't tolerate it and will have reactions to certain things that I've never ever seen before. And it's been making me think about what exactly is their trauma history and why we can't make them feel better no matter what we try.
No, I 100% agree with that. I'm seeing it more and more. And I think it's twofold, Christine. I think where it comes from is the four of us are now in private practice and we own our own clinics and we do things the way we want to do them. We do exams the way we would want exams done to us. It's very much kind of that golden rule without like do unto others as you want them to do unto you. And we get to choose what we're going to put on our intake, how we're going to listen to our patients. And I think what sets us apart as clinicians is that we take so much time to listen because we have the availability to do that. And I'm not saying that I didn't listen well in my 20 other years of doing women's healthcare. It's just the time constraints, the insurance model, and other things did not allow us the time to clinically listen. It's one of the big things that I write about in trauma-informed care is if you listen to your patient, they will guide you on the diagnosis, even if you have to multiple times. And I think what we continually hear over and over, and maybe why they don't respond to treatments, is because these patients are also the more difficult patients that may have that high histamine level. They also have nervous system dysregulation. They have the dysautonomia. They have probably some of that mast cell. Potentially, these are also the patients that are presenting with POTS or with MCAS, and they've been denied so many different ways of being cared for in the system. And so then there's that whole medical trauma, neglect. They've tried something or they were told they're crazy, it's in their head. And so there could be some of that parts and pieces in their brain where they're like, no, it's not going to work. But truthfully, they also may have histamine intolerance and then that over active nervous system. And that, as we know, really, really affects hormones.
I think there's a couple good points that I wanted to go back to. One would be, I think probably in primary care, this can be done a little bit easier, that before a pelvic exam is done on a patient, we should be meeting them first, right? So if a patient's coming new to you, maybe a pap smear isn't the best thing to be coming new to you for, right? So you can meet them first. It's called an established visit, right? You're establishing to the practice where you can talk with them. And I think we just need to remind patients that in an insurance-based model, you can ask for that. You could ask to meet the physician and talk about, if it's a GYN solely that you're going to meet them for, maybe you talk about your period history and your contraception needs and other needs before you are going to get undressed. But I think that's something, it's such a good point that you said, because I'm thinking to myself, have I ever not met anyone that and I think I don't know that I have. I cannot recall if I've ever not had a patient that I've already had established some type of rapport with before doing a pelvic exam, because it's such a sensitive situation. Feeling off in midlife? I'm Dr. Rebbecca Hertel, and I offer concierge telemedicine across multiple states focused on hormones, weight, libido, and sleep, and longevity. Let's get you thriving. So visit www.osteopathicmidlifehealth.com.
Their first GYN visit as their annual.
Yep.
Yeah. Yeah. And they all do that with me too. And you have to, talk about those things. And those, like you said, those need all that extra time so that you can explain the whole entire process to them and every step of the way.
Exactly. And like you said, we don't have as much ability, like you said, when they do that in a GYN exam. But primary care, it does make it a little bit nicer because maybe they're coming to you for hypertension or for cardiovascular or their statins or things. And it definitely makes it a little bit easier.
Yeah.
Mm-hmm.
And then my second question is do you find that in the perimenopause and menopause transition, that's when some deep trauma history then starts to become uncovered, is in that transition? Maybe they never remembered it. They didn't recall why they were having issues with either intimacy or other relationships. But now this perimenopause and menopause transition has uncovered those things. Do you find that a lot in your practice as well?
Yeah, absolutely. I find that it uncovers something, or they go through the perimenopause transition a lot more difficultly. I don't even think that's a word, but it's a lot more difficult for them as they ease through that transition. And we know that because there's actually evidenced articles that women that experience a history of trauma, their menopausal symptoms are often worse during during the transition. So why wouldn't perimenopause be worse? We know that perimenopause is a time of complete disruption in the body. The normal, and who's normal? Let's be for real, but the average person often feels like completely out of their own skin, or as Aoife had said, it presents as feeling just completely just exhausted and out of their own scope, or burned out, as you said in your article, Aoife. And so when you add that trauma history to it, they're going to be even more disrupted because of that nervous system dysregulation.
And when someone comes in, Heather, and they do have a history of trauma, how does that show up in the exam room, with regards to their pelvic floor, their sexual response, their hormones?
Absolutely. So oftentimes I will see that when they do come to the exam room, like I said, some of those symptoms that we had talked about in the beginning of the podcast is that it'll show up as tightening of the pelvic floor for sure. You go in, you do an exam, and when you go in to do a pelvic, sometimes you may not even be able to insert even a pinky finger in there to assess the muscles and the uterus and the ovaries and to check. So just that tightening. They also, like I said, present in a lot of ways where maybe they want to talk about their low libido or their pain with sex or their inability to orgasm, but they're afraid and they keep dismissing it and saying, oh, it's not a big deal. Or, oh, they told me it was in my head. And so I find that oftentimes my trauma patients are the ones that I'm often finding that continually apologize to me. I don't want to take any more of your time, or that must be a dumb question, or it's not that bad. It doesn't matter to me.
And when you are seeing these patients, how do you tease apart hormonal trauma, the hormonal compartments, the trauma compartments, without making them feel like there's, pathology there, or they're pathologizing themselves? I'm not sure that was a real word either.
Yeah. And I think, and again, I think that's where it gets really, really tough, is kind of teasing it all out and really spending all of my years in trauma informed care and kind of teasing that. I never am going to start something out by what's wrong with you. I always, I think our words and our choice and how we talk to every patient, again, if we come to every interaction that there's a history of trauma, it's going to guide how your visits and how your discussion will go. So normally I start with, tell me your story. Tell me what's been going on. Tell me the whole thing. If you've seen 17 providers before you see me, which is usually the case in sexual medicine, I want to know. I want to understand. I want to understand what you've been through. And then it's kind of piecemealing through the three lenses at the same time. Like we're looking at like tissues and hormones, the relationship context, the nervous system context. And then I have lots of different questions that kind of help me decide, like, okay, if it's more of like a tissue, a hormonal thing, is it because tissues are tight? Are you having vaginal dryness? Are you having burning, UTIs, like those kind of things? And then we get into kind of, I do a lot around anatomy. I talk to patients like, do you understand where your body parts are? Like, where is the pain happening for you? And if they can't pinpoint the pain, then we kind of have to tease, is it a hormonal thing? Is it in the vestibule? Is it in the vulva? Is it in the vagina? Or is it more of just this psychosomatic piece, because there is this history of trauma? We go in and when they're comfortable and do an exam and we don't see anything that looks architecturally wrong, or you do a Q-tip exam and they're not having pain, then it's kind of going through telling them, okay, well, a lot of this can come from potentially trauma. Tell me what that looks like for you, and ease into it slowly. I always really try to explain to patients, like I said earlier, big T trauma and little t trauma. Everyone in this world usually thinks about that big T trauma as sexual assault, and trauma doesn't necessarily always exist as this big sexual assault. It could be that maybe when the patient was with a previous partner, they didn't make your patient feel comfortable in their own skin. Maybe they judged them and just say, hey, that dress makes you look like your stomach feels more bloated or something. And so that you can internalize so many things that people may say to you. And then in theory, when you go to be intimate with that person, you're like, oh, I can't be intimate with that person. I would feel uncomfortable being naked with them. And then there is that psychosomatic brain piece that's like, okay, how does your partner make you feel? I mean, one of the first questions I always ask as I'm kind of going through like sexual health and HSDD on hypoactive sexual desire disorder, the first question I ask, number one, is, do you like your partner and does your partner treat you okay? Because I can fix a lot of medical problems and I can even send you to therapy. But if you actually don't like your partner or you don't feel safe in the relationship, then that's hands off. I can give you all the testosterone or all of the non-hormonals over the world, and we're not going to fix that sexual health concern.
That's a great point. I think you're a great point too about just trauma itself, that and also somebody's big T trauma might be somebody else's little T trauma and vice versa, right? Like it's kind of like a pain scale. Like it's so subjective to one person.
Yep. And I think you have to really make your questions really concrete for them. Like, okay, you say it hurts when you have sex. Does it hurt on entry? Does it hurt with deep penetration and thrusting? Is it burning? Is it raw? Is it achy? Like, have them really describe it for you. When you're talking about just like desire and arousal, there's ways that we can word the questions to help them listen and tell their story.
And I think this, like providing this information for the women that aren't clinicians that are listening to this, what advice would you give them for, how to maybe answer questions for providers, or what information that they being more upfront with would be helpful?
You mean for patients, like what?
Yeah, because we kind of talked about all the things that the clinician, but
Mhm.
a lot of people listening may be patients.
Yeah, yeah. I think if patients could try to be descriptive as best as they can to help providers understand like what they're feeling inside. So if they come to you, like it's not an easy example, it's probably the hardest thing we do, but pain with sex, knowing kind of where the pain is happening. Does it happen every time you have sex? Is it on entry? Like I said, is it with deeper penetration? What does that feel like for you? Does it happen when something is kind of provoking it, where it's hitting onto your female parts, or does it happen all the time? You and I are sitting here. One of the questions I ask them, when you are sitting here with me in my office, are you feeling pain in your vulva and vagina at this time? Because then we explain to them that's called unprovoked pain, meaning that nothing has to touch it and you have pain. Like, what does that look like? And really kind of helping them kind of unravel the pieces. Also knowing, like, does it itch? Does it sting? Does it burn? There's a big difference between a burn and an itch. And itching presents itself differently in different clinical scenarios. So the more details, descriptives, and things that patients can give us, the better. But also know if patients come to you with a history of trauma and it's related to, let's just say, a sexual assault or something, they may disassociate and not even be able to to tell you that. And so you're going to have to try to drive some of those questions out of the patient as a clinician.
Yeah, absolutely. And I think too that's, another thing, to help make the exam less triggering is clicking. No speculum should be clicking in an exam room. That drives me absolutely insane. And you don't have to use the biggest speculum. I use the tiniest speculum on 99% of my patients and can
Yeah.
get
And
a
ask,
perfectly good exam.
right? And ask. I think just asking. Like, we
Yes.
know what size we like, or, or at least we think we do. And I think when you give that control back to a woman, even if you just ask, I've never been
Yep.
asked what size. I actually
That's
like
why.
the smaller size or the medium size.
Exactly. That's kind of what we built my personal podcast on, was it's called Just Ask, because no one's asked. They're not asked anything. They kind of are just like, okay, here's speculum, wham, bam, here we go. We're getting your PAP, and you don't necessarily need to get a PAP either on first time. Sometimes I'll just start with a pinky and say, we'll start here, because you have to remember the people that come to you with an experience of like sexual assault trauma, for example, a pelvic exam is incredible. And a lot of times their body is going to shut down because that is their defense mechanism of protecting things, is that I explain to patients, it's not your fault that sex is painful, or it's not your fault that those muscles tighten, especially with a trauma history. It is our brain's response on protecting the body. And that's kind of one of the things that I tell women that have experienced a rape or a sexual assault, is it's our body's protective mechanism kind of protecting ourselves. And when it's ready to feel like we're in a protected space, sometimes those muscles will just slowly not be so tight with a lot of pelvic floor, a lot of therapy, and a lot of things.
Want the Dusty Muffins at your next event? We do panels, live podcasts, and talks that bring the heat, literally. Corporate, see me, or retreats, we've got you. So hit us up at thedustymuffins333@gmail.com or DM us on Instagram at thedustymuffins.
The other thing we wanted to talk to you about today, Heather, because of your experience with this, was trafficking. And again, for our listeners, we're not talking about any particular stories. We're just talking to Heather about her experience in this field, because you really do have amazing experience, and think it'll be so educational for any clinicians or anyone, any lay people listening today. But from a clinician's point of view, what are the signs that you might see when you meet somebody in the exam room that could suggest they're being trafficked or controlled?
Absolutely. So interesting. One of the interesting things, and I feel like sometimes on these bigger platforms, I always want to say trafficking is happening in your backyard, whether you think it or not. I think one of the most important things I always want to start off with as a header is that trafficking exists everywhere. It is not an out of the United States problem. I was doing a project with one of my sons here locally in the Georgia area. It was actually his Eagle Scout project, and something that just triggered the life out of me. And I was so frustrated, and I very much gave my opinion, is that when we were doing the project, it was actually for the Emergency Stabilization Center that I helped to create here in Georgia. And his Eagle project was creating a little library for the youth at the trafficking center. And one of the family members said, you started emergency stabilization. We have a traffic center here. And I'm like, yep, it's actually one county over from where I am. Really, because there's no trafficking here in Georgia. And it just kind of caught me dead in my tracks. And I was like, actually, it is a global, huge problem, but it exists in the United States. The Super Bowl, for example, is one of the hotbeds, the hottest bed of all hotbeds of sexually trafficking of minors. Also, given what has been going down with the Epstein files and things, it is happening here on U.S. soil. And I cannot stress it enough that we need to be so hyper vigilant about watching this across the United States everywhere. But to get back to your question, I just, like I said, I cannot come onto platforms without just saying it is a global problem, and it's often overlooked. And one of the biggest things when I go present about trafficking and trauma across the country and internationally, just to kind of hone it in, and again, this is another kind of trigger thing, it is a much bigger hotbed than drug use and selling of drugs, because with drugs, it's a one-time use. The trafficking industry is a multi-billion-dollar industry because you can sell a girl multiple times a night, up to 7 to 10 times a night. So it is a massive global pandemic, a global emergency. And it unfortunately makes the perpetrators a ton of money, much more than the drug industry.
Mhm.
Easy to hide it in plain sight rather than drugs.
You get nervous then when you see men coming into insisting on being in the exam room with women?
Yeah. So kind of to answer some of your questions, that definitely makes me concerned. When I have a patient that comes in and says, I would love my partner to come in, I am a huge advocate when we're dealing in the world of sexual medicine. Bring your partner in. If I can explain to them what your anatomy looks like, what's causing the pain, all the things, I am 100% for the couple to be involved in it. But there is a feeling, and I don't even know how to describe it to you except to kind of talk to you about symptomatology, that when someone is trafficked and their perp wants to come into the exam room or be there for them, it will raise every hair on the back of your neck, because it just presents differently. It's very much a very controlled dynamic. So oftentimes what we find when the perp comes in with their trafficked victim is that a lot of times they will answer the questions for them. Usually what we find in, for example, I'm not saying that boys don't get trafficked. Absolutely they do, but I'm just going to take this in the case of a female just because that's my world and that's more what I see. I'm also not going to tell you that perpetrators are only men. Perpetrators are women and they're men, and perpetrators, to be honest, look like the four of us. They look like potentially our spouses. They look like people that look just like us, that are in the type of environments that we are. That's how terrible it is. But usually when a perp brings their female in, for example, into an exam with me, they're always going to answer their questions. They often will interrupt the trafficked person, and oftentimes they don't let them speak. Usually you get a little bit of refusal by the companion to leave that room. When I can see something that doesn't feel right to me or that's off, usually I will try to say, hey, I need to get them a urinalysis. So I'm going to let you stay in here. We're going to go grab a urine and we'll come right back. And usually we have some sort of something in the exam rooms where it's like, check a red box if it's an emergence, like check the box here. We usually have, like, in places where I've worked in primary care, we have like 2 colored pens where we can even get them alone for 2 minutes just to be like, do I need to call help? What can I do to help you? So those are things. Usually the companion's going to hold the person's ID, money, their phone, maybe their paperwork. Oftentimes the victim doesn't usually have a form of identification. So if you try to maybe get a driver's license or something from these people, oftentimes they don't have it with them, or a social security card, or nothing. Sometimes if you even try to ask them, where are you located? Sometimes they've gone across state borders because they go from maybe truck stop to truck stop. That's a hotbed for trafficking. You always want to be hyper vigilant when you go to a rest stop or a place to pull off the side of the road to use the facilities or something, that is a hotbed for trafficking. And it's usually moving people across borders. So sometimes they won't even know where they've been. So you may say, you're here in Georgia, in Kennesaw, and they are just like, no, the last time I remember anything, I was in Washington State. So that should again raise red flags. They also are very afraid to kind of disagree with the companion. So those are some definite things. If the story sounds scripted, or there's inconsistencies, or there's injuries that aren't explaining things, or maybe you see bruise markings or things where maybe they've kind of yellowed in color, or things have kind of changed from like healing, those are things to be really vigilant about. Like, where did that bruising come from? Again, it's unclear kind of where they live, or maybe no stable address. These are also patients that oftentimes will present in your clinic, especially in clinics that are like free clinics and maybe like health departments where they're only coming in for an STI examination. So they usually don't want the exam. They will tell you, I think that I had an encounter, like a quick exposure. It's kind of some made up story. I just want the medication. And usually what I go and tell patients or tell clinicians when I talk about this, like all over the country, give them the dang medication, because it may be the only time that they actually get to your office where you can treat a potentially sexually transmitted infection, or you can keep them from getting like a pelvic inflammatory disease. I usually will treat them immediately, but I also try to get some clarity if they're open to it. These patients are also going to present very hypervigilant. They're like startled very easily. They're very submissive. They're overly agreeable because they've been controlled for so long. So I always tell people that if you have this inclination that something just feels off, as a clinician, you just need to kind of go with your gut around that and see what you can do to help.
Is there anything you shouldn't do in particular?
I will always say what you shouldn't do is to try to address it if the perpetrator is in the room with them. So don't ask any questions about trauma. Don't insinuate any kind of trafficking. The best thing you can do is try to get them for even a minute by themselves if you can. And then the other thing that you should probably try to do is maybe warn your staff, because they may be able to kind of help. But just, I usually say, try not to give the perpetrator too much of the, you have something that's not feeling right in your head, because they're going to be really off and they may just rip them out of there. And that may be your only interaction too.
They say, yeah, I need help. What do you do then?
So that's where you really need to know where your resources are. Can you call are you in the hospital? Do they present? Like a lot of times the girls that have come into my trafficking center have told me before, I presented to the emergency room no less than 5 times and no one did anything to help me. And so if you're in a hospital setting, it's knowing how to call, like knowing in the emergency room where your immediate access point is to get social worker involved. Like ASAP needs to happen immediately. We can't wait because they may walk them out of here. Knowing kind of where your resources are when you're in private practice probably takes a little bit longer, but trying to kind of use some stall tactics. They may rip them out before then. Trying to find a place they can tuck away a number or something in a shoe, in the sock, something to kind of have their sources. But I think it's on us as clinicians to kind of know where our sources are. There's a lot of different resources out there. RAIN, I think, is one of them. RAA, I'm looking it up right now because I always forget. It's RAIN, and it's the Rape, Abuse, Incest, and National Network, kind of knowing where that is. There are some other ones like the Global Trafficking through the U.S. Department of Health, but just kind of knowing where your resources are in your general vicinity, I think it's really important to kind of stay hyper vigilant on that as a clinician, just so that you have a quick and fast place that you can look for those.
So if somebody says, yes, I want help, and you're in the ER or the hospital, you're thinking social worker. And if you're out in the clinic, you're contacting maybe somebody like RAIN, you're not calling 911.
You absolutely can call 911. There's not a problem with calling them. The problem is it may take them a little bit to get to you and you're looking for something kind of immediate. If you're listening to this podcast, for example, and you're already kind of thinking, okay, I need to know where my local resources are, is getting in there and having like an office meeting to say, here's where our local resources are, just so that you know before it shows up on your door is usually what I recommend. And it's going to be different all over. There's like a national human trafficking hotline that you can go to. You can text on there. It's confidential. And so I can give you some sources that you can put in the notes of the podcast just to link to.
Be great. Yeah. And so if anyone's listening to this who is being trafficked, that number that you can text sounds very helpful.
And the problem is that usually as a clinician, you're probably going to have to do that for them and maybe have some stall tactics because most of the time, the person that is trafficked that presents to your clinic often won't have a cell phone. Oftentimes, those have been taken away from them. That also should raise some not interest, but that should also raise some questions in your head. Like everyone and their mother, for the most part, has a cell phone. Even my 92-year-old mother knows how to use a cell phone. So if they're not able to access it or don't have a cell phone, like that should just kind of start to raise your curiosity a little bit.
Things that we don't want to think about, but you're right. It's in every community. And that's just the reality. And so I think as, those that are in primary care, those that are in GYN care, those that even see young adults, children, or talking even with parents, I think we just need to make sure that that's just part of our teaching all around whatever setting that you're in as a clinician. This really needs to be part of our education and treating, especially now that all of these children, young adults, have cell phones, have a way that traffickers can get to them.
Yeah.
I have that number. So it says for immediate assistance, call the National Human Trafficking Hotline at 1-888-373-7888. And we'll put that in the show notes as well. And it's open 24 hours a day, 7 days a week in more than 200 languages. So that's a good number to have tacked up in your clinic.
Yes.
Room, in the staff room, in the bathrooms.
Most places have those in the stalls of the bathrooms.
Airports or a place tucked in, maybe where you do a urinalysis. That's where I tend to find is the easiest, where they have to fill out a little card with their name on it. And there could be a different card or a card that you can hand them when you take them to leave a urine. That's always that's always like the de facto, as best as you can. Hey, I need to get a urinalysis. And usually that's a place where you hopefully can get them for like 2 to 3 minutes.
And you helped start Georgia's first human trafficking emergency stabilization center, Heather. So what does that involve?
Yeah, so it wasn't the first. So what it was it was the first for youth. So in our facility, it was a joint effort between the First Lady of Georgia had some initiatives, and one of her initiatives was kind of to end human trafficking. And so we were tasked to put together with grant funding and other things, an emergency stabilization for trafficked youth. So that included males, females, and transgender and gender nonconforming youth from the ages of basically 12 to 17 here in Georgia. So people would find the facility either through um, health and like family services, DFAS. Some of them were brought over through the police departments, through other ways, child protective services. But what it is we put together a program with Wellspring Living, which is a nonprofit here in the Georgia area that had been caring for women of trafficking, traffic youth, but really hadn't focused on the piece of emergency stabilization. And so what the emergency stabilization piece was it's a 90-day facility. So youth had the ability to go into the facility. They were given sexual assault exams if they needed it. The component that I built was the medical component that was able to help with the emergency sexual assault exams and then the everyday primary care needs for these patients. So whether they were on meds for psych or meds because they needed birth control or STIs or they had an upper respiratory infection or things of that nature, in those 90 days, they were able to have medical needs taken care of. They were in school. So they did their virtual school online. We have a school inside the program that is run by 2 teachers and a principal. And so they are virtually able to connect with the county that the facility is set up with so that they get their 90 days of continual schooling. And then they also receive psych services. So they had all those different needs met in the facility, and then it's residential. So they sleep there. They have their own bedrooms, their own bathrooms. We were able to take up to 20 youth at a time. And it's a wonderful option because what it does is it takes them out of a horrific environment. It puts them in a facility where they can have their needs met for 90 days while we kind of emergency stabilize them and then gets them to whether they go, whether it's in a group home or whether it's out for adoption, or have they met the need of that they're almost 18 and then they can go on to maybe living in a group type of like adult type of situation.
Amazing setup.
Yeah, it really is an awesome setup. And over the time, we started it just right pre-COVID. So it opened in March of 2020. And through the last several years, we've taken on probably over 100 youth per year in the program. And we've been collecting data. I was able to actually get our first journal published about the trafficking center, and some of the statistics that we have been collecting over the 5 years has been super interesting. Like 99% of our patients are runaways, and runaways usually within the first 48 hours of being a runaway are already picked up to be trafficked. The amount of drugs that these patients use, with the highest being marijuana, but we've seen all facets of drugs. We've seen cocaine, we've seen heroin, We've seen a lot less of like the oxycodone and things like that because it's super expensive, but most of them are using some form of drug. And then the other really interesting variable, and I don't have the numbers on this, but what tends to be one of the biggest things that we have found in our personal data is just the LGBTQ population. And I think a part of it for us is that we're in the deep South. And so a lot of things are not wildly accepted out here. And so these teens are often pushed out of their homes for not conforming to the typical American youth. So there's a really high prevalence of LGBTQ youth that are trafficked.
So these youth would be maybe at the bus station or train station, leaving home, and that's where these traffickers are waiting to pick them up, offer them like somewhere to stay or...
Yep. Offer them somewhere to stay or a job, or maybe they're already on some form of illegal substance and a way to get their substance. And oftentimes when you would talk to these youth, they don't even necessarily sometimes realize they may be getting trafficked because they are just using their body in a way to get money to pay for things on the streets so that they can survive. So like they don't even understand their anatomy. One of the big things that I really have enjoyed over my time is going in there and just teaching them about sex ed. It's amazing that they don't know what their body does or how they get pregnant or where a baby comes from. And that's just so sad given the fact that they are so exploited.
Well, we'll tell our listeners here where they can find you and all of the amazing things that you do, whether it be on social, where they can find you for your practice. And we'll also make sure to link all that in our show notes. But this has been a pretty amazing conversation. Thank you so much for
Thank you
joining
guys.
us.
Thank you so much for having me.
Thanks,
So yeah, I have my own personal practice, the Show Center Sexual Health Optimization and Wellness in Kennesaw, Georgia, www.theshowcenter.com. I focus on midlife sexual health, thyroid, weight loss, all the things for the midlife woman. And then I also have another platform called the Q Spot, Q like Quaile. Evidence-based education at your fingertips, no pun intended, or maybe there was a pun intended with that. But it actually is my platform for training clinicians on women's healthcare, business startup, weight loss, menopause, all the things. And then my Instagram is at Dr. Quaile NP.
All your content is amazing.
Yes.
Your Instagram, everything, Heather. Yes, you just do everything so well.
Thank you so much.
All right, everyone. If this episode shifted something for you, whether you're a patient, a partner, or a clinician, that's the point. Women's healthcare does not have to feel rushed, dismissive, or transactional. It can feel and should feel safe. It can feel informed, and it can and should feel dignified. And conversations like this are how we change the culture. If you found this helpful, do us a big favor and follow the Dusty Muffins wherever you listen to podcasts. Share this episode with a friend or a colleague, and please leave us a review. It helps more women find this information. And the more we grow, the louder this conversation gets. Heather, thank you for the work that you do and for being here with us. And to our listeners, take care of yourselves and each other, and we'll see you next time.